Okay, so moving on to section 4, we're going to talk about the first step, where we're actually having glomerular filtration occurring. The process of glomerular filtration is passive, meaning it doesn't require any energy. What it's actually using is hydrostatic pressure, and this hydrostatic pressure is going to force fluids and solids through the membrane. So we can kind of view our glomeruli as like filters. And because we're filtering something that doesn't directly consume any type of metabolic energy. So let's look a little bit at the filtration membrane. And the filtration membrane is going to lie between the blood and the interior of the glomerular capsule. It is porous because I'll show you in a second. We have those foot processes of our podocytes. And this porous membrane is what's going to allow free passage of water and solutes that are smaller than the plasma proteins. Because remember, we don't want to push our proteins or our cells through, but we really want everything else to go through our through this filtration membrane. So we do have 3 different layers. The first layer is the fenestrated endothelium of the glomerular capillaries. And the fenestrations or the capillary pores allow all of the blood components except the blood cells to pass through. The next layer is going to be our basement membrane, and this is going to lie between the other 2 layers, and it forms a physical barrier that helps block all but the smallest proteins while still permitting most of the other solids to pass. Our third layer is going to be made up of those foot processes of those podocytes of the glomerular capsule. And remember, this is our visceral layer of the glomerular capsule. And those foot processes have or make up filtration slits. So if any macromolecules manage to get through the basement membrane, then we have cells there to help prevent them from traveling further. So this image is just kind of showing you what we're talking about when we're talking about glomerular filtration. We're feeding in our blood through here, our afferent arteriole, which is going to form our glomerulus, which is this ball of capillaries right here. So our filtration membrane is the membrane from these blood vessels right here, getting our filtrate from the blood out and filling this Bowman's capsule, where it'll eventually go into the proximal convoluted tubule. So again, what we want to push through or push out into our capsule is everything that's being brought in from our blood, with the exception of cells and proteins. So how do we allow everything to go through except for cells and proteins? Well, we use the filtration slits, which are the slits or the spaces between the foot processes of the podocytes. So here's a podocyte here, and here's all of its little foot processes here. The spaces between the foot processes make up the filtration slits. So they're kind of appropriately sized so that everything can cross except for proteins and cells. Because the goal of filtration is really we're putting everything into our filtrate, and then we're going to reclaim back what we want and then leave in there what we don't want, which eventually will become our urine. Sometimes we do get larger molecules or macromolecules stuck in those spaces between the foot processes, but we do have a cell, mesangial cells, that can come in and engulf them and get rid of them. So really, when we're talking about the spaces between the foot processes, they can allow molecules that are smaller than 3 nanometers to pass. So things that can pass are things like water, glucose, amino acids, and nitrogenous waste. What can't pass are plasma proteins. So those remain in our blood, and they also help maintain our colloid oncotic pressure. And this helps prevent the loss of all the water from our blood into the capsular space. So we do have some things that can affect filtration. Remember, when we're talking about filtration, we're talking about pressure being what allows for filtration to occur. So we have outward pressures, and these outward pressures are going to be promoting filtrate formation. So the outward pressure, the most prominent one, is our hydrostatic pressure in our glomerular capillaries, which is abbreviated as capital H and capital P and a subscript of GC for glomerular capillaries. And this pressure is essentially the glomerular blood pressure. It is the chief force that's pushing the water and solutes out of the blood and across the filtration membrane. The blood pressure in the glomerulus is really, really high. It's about 55 millimeters of mercury compared to other capillary beds, which have a pressure of about 26 millimeters of mercury. And it's going to stay high across the entire capillary bed. And this is because our glomerular capillaries are drained by high-resistant efferent arteriole who has a smaller diameter than the arteriole that feeds into them. So if you think about a high pressure, and I'm drawing this incorrectly, but it's just for demonstration. If this is our glomerular capsule here, this is our afferent arteriole. This would be our efferent arteriole. So our afferent arteriole has a much larger diameter, and our efferent arteriole over here has a much smaller diameter. So if you can imagine, we're pushing in and bringing in way more blood than we're allowing to leave, and that allows this pressure to build up in the glomerular capsule. And that is basically our hydrostatic pressure in our glomerular capillaries. Theoretically, we could have another pressure, which we refer to as colloid osmotic pressure in the capsular space, and this would pull filtrate into the tubule itself. But we consider it zero because virtually no protein should be entering into the capsule. So really only one major outward pressure, but we do have two inward pressures that act to inhibit filtrate formation, meaning that they oppose our HPGC. So our first one's going to be our hydrostatic pressure in the capsular space. And this pressure is exerted by the filtrate that's in the glomerular capsule. So once we push the filtrate through our capillaries out into the capsule, that filtrate is pushing back on the capillaries. So our hydrostatic pressure in the capillary space is much higher than the hydrostatic pressure surrounding most capillaries because that filtrate is confined to such a small space and has that narrow efferent arteriole to feed out. Our second inward pressure is the colloid osmotic pressure in the glomerular capillaries, and this is the pressure that's exerted by the proteins in the blood that kind of sucks water back into the capillary itself. So that leads us to what we call the net filtration pressure, in which we take into account both of the pressures that we have, the outward pressure that we have, and then the two inward pressures that we have. So like I mentioned, our outward pressure of our hydrostatic pressure in the glomerular capillaries is about 55 milliliters of mercury, acting to push out our filtrate into the capsule. And then we have inward pressures trying to take the filtrate that's in the capsule and push it back into the capillaries. Collectively, the two inward pressures are about 45 millimeters of mercury. So we still get a net outward force of about 10 millimeters of mercury. So that's the pressure that we're using to push the filtrate from the blood into the capsule itself. So this is just a diagram illustrating to you the different pressures that we talked about. This is our outward pressure, which is our hydrostatic pressure in the glomerular capillaries. So this is coming from the fluid in the capillaries themselves, trying to push filtrate into the capsule. And then we have our two inward pressures right here, our osmotic pressure in the glomerular capillaries, which is basically the proteins that are in our capillaries kind of sucking the water back in. And we have our hydrostatic pressure in the capillary space as our other inward force, which is the pressure from the fluid that's in the glomerular capsule pushing back on the fluid that's in our capillaries. Regardless, we should always have a net outward force in order for us to properly form the filtrate. So that leads us to something called the glomerular filtration rate, or GFR. And GFR is the volume of the filtrate formed each minute by the combined activity of all 2 million glomeruli of the kidneys. So we have about 1 million glomeruli in each kidney, so 2 million collectively. And our glomerular filtration rate is going to be directly proportional to the following things. So the first one it's going to be directly proportional to is the net filtration pressure. This is our main controllable factor. This is the primary pressure that we talked about, is the glomerular hydrostatic pressure, or the pressure pushing out. And it's controlled by changing the diameter of the afferent arteriole. So if we make the diameter even larger than it already is, that would increase the pressure even more. If we constrict the afferent arteriole to have a smaller diameter, then this would lower the pressure. Also, the total surface area that's available for filtration. So those glomerular capillaries have huge surface area. And our glomerular mesangial cells can control the surface area of these capillaries by basically contracting to adjust the total surface area needed for filtration. And our glomerular filtration rate is also directly proportional to the filtration membrane permeability, what it's actually allowing to go through. So how do we regulate glomerular filtration? We want to keep a relatively constant glomerular filtration rate to make sure that our kidneys make the filtrate and help maintain extracellular homeostasis. So the goal of the local intrinsic controls, which is also referred to as renal autoregulation, they basically act locally within the kidney to help maintain the GFR. When we're talking about extrinsic controls, we're talking about nervous system and our endocrine systems helping maintain our blood pressure. And if we have any extreme changes in our blood pressure, our intrinsic controls will take over. So the GFR is controlled by changing our glomerular hydrostatic pressure, and all mechanisms act to basically change the glomerular hydrostatic pressure. Okay, so let's talk about the intrinsic controls when we're talking about renal autoregulation. So we're talking about adjusting its own resistance to blood flow. So the kidneys can maintain a relatively constant GFR despite all the fluctuations we have in our arterial blood systemically. So the renal autoregulation uses two different mechanisms. We have the myogenic mechanism and the tubular glomerular feedback mechanism. So the myogenic mechanism is really going to reflect the property of our smooth muscle that we have in our vasculature. So it contracts when it's stretched and it relaxes when not stretched. So if we have a rising, systemically rising blood pressure, this is going to stretch our vascular smooth muscle in our arterial walls, causing the afferent arterioles to constrict. And the purpose of the constriction is to help restrict the blood flow into the glomerulus and help keep the glomerular filtration rate at its constant level that's ideal for kidney function. Declining systemic blood pressure is going to cause the opposite to happen. So we're going to dilate our afferent arteriole to help raise that glomerular hydrostatic pressure. But both of these responses are actually needed in order to help maintain our net filtration pressure as well as our glomerular filtration rate. Okay, our other mechanism is the tubulo-glomerular feedback mechanism. And this is really directed by those macula densa cells that we talked about that are a component of the juxtaglomerular complex, or the JGC. And these cells are in the walls of the ascending limb of the nephron loop. And remember, they respond to the sodium chloride concentration that's in the filtrate. And the concentration of sodium chloride does vary with the filtrate flow rate. So when our GFR increases, there isn't enough time for the reabsorption, and the concentration of the sodium chloride in the filtrate stays really high. So the macula densa cells can sense these high levels of the sodium chloride in the filtrate, and they release these vasoconstricting chemicals that are going to cause constriction of the afferent arteriole so that we lower the blood flow into the glomerulus. And if we lower the blood flow in our glomerulus, this is going to decrease our net filtration rate and our glomerular filtration rate, helping slow the flow of the filtrate to allow more time for processing and therefore for sodium chloride reabsorption. The opposite is going to be true if we're talking about low sodium chloride concentrations of filtrate that's flowing slowly. So we're actually going to inhibit release of those chemicals from the macula densa cells, which is going to cause vasodilation of the afferent arterioles, which is going to allow more blood to flow to the glomerulus and increase our net filtration pressure as well as our glomerular filtration rate. So our extrinsic controls are a little bit different. The purpose of the extrinsic controls and helping regulate the GFR is to maintain our systemic blood pressure. So in the event that our intrinsic controls are not doing what they need to do, our extrinsic controls can override it and they can go in and take over. So our sympathetic nervous system, if we're under normal conditions at rest, the renal blood vessels are going to be dilated and our renal autoregulation mechanisms are going to be taking over. But when the extracellular fluid volume is really, really low, so for example, if we're in hypovolemic shock or if we're hemorrhaging blood, then it's going to be necessary to shunt the blood to the vital organs, and the neural controls may override our autoregulatory mechanisms. So when blood pressure falls, what's going to be released by the sympathetic nerve fibers is norepinephrine. And norepinephrine is going to cause our vascular smooth muscle to constrict. This is going to increase the peripheral resistance, helping bring our blood pressure back up to normal. So this is what we refer to as the baroreceptor reflex. As part of this reflex, the afferent arterioles also constrict, and constriction of the afferent arterioles decreases the glomerular filtration rate, so it helps restore the blood volume as well as the blood pressure. The next mechanism we've talked about a couple times before, but it's our renin and angiotensin-aldosterone mechanism. And we talked about this, I think, in chapter 19. And this is our mechanism for increasing our blood pressure. Because if we don't have the right blood pressure, glomerular filtration is not going to occur. So this mechanism regulates glomerular filtration, the glomerular filtration rate indirectly. So low blood pressure causes the granular cells of the GJC to release renin. And there are 3 pathways that stimulate granular cells. One of which could be the sympathetic nervous system. So as part of that baroreflex we just talked about, the renal sympathetic nerves activate the beta-1 adrenergic receptors that cause granular cells to release renin. We can also activate macula densa cells. Low blood pressure or vasoconstriction of the afferent arterioles is going to reduce our glomerular filtration rate and slow the filtrate flow through the renal tubules, which means our macula densa cells are going to sense that low sodium chloride concentration, and they're going to signal the granular cells to release renin. So they may signal it by releasing different chemicals, but either way, they send the signal. Okay, the third way that we can stimulate granular cells is reduced stretch. So our granular cells act as mechanoreceptors. So a drop in our mean arterial blood pressure reduces the tension in the granular cells' plasma membranes, and it's going to stimulate them to release more renin. We do have other factors that can affect the glomerular filtration rate. So our renal cells can release, a variety of chemicals, some of which can act as paracrines, which are just locally acting signaling molecules that go to affect our renal arterioles. So things like adenosine or prostaglandin E2. Also, the